Good morning and welcome to UroNurse News. You know the drill. Today we're looking at a major step forward in prostate cancer early detection, the PATROL study, short for Prostate Cancer Screening for people at genetic risk of aggressive disease. This study focuses on individuals who carry inherited genetic changes known as germline pathogenic or likely pathogenic variants that increase the risk of developing prostate cancer. These include well-known high-risk genes such as the BRCA2, BRCA1, HOXBIG13, ATM, CHEK2, MSH2, MSH6, and TP53. Now, concurrent NCCN guidelines already recommend more attentive screening for these patients. But what we don't fully know is the best way to screen them early enough to catch clinically significant disease. That's where the PATROL study comes in. The PATROL study is a multi-center, prospective, early detection trial designed specifically for people who are genetically predisposed to higher prostate cancer risk. To qualify, participants must be 40 years or older, carry a confirmed risk-associated gene variant, have no prior prostate cancer diagnosis, and no other active malignancy at enrollment. Once enrolled, patients undergo a structured screening pathway. This includes annual physical exam, yearly PSA testing, and optionally an MRI at baseline. Multiparametric MRI becomes particularly important if PSA rises above protocol-defined thresholds or clinical concern emerges. One of the most important innovations in this study is the use of age-adjusted PSA thresholds to guide biopsy decisions. Here's how it works. For individuals under 50, biopsy is considered if PSA is greater than 1. And ages 50 to 59 threshold increases to greater than 1.5. And for those 60 or older, biopsy is recommended if PSA is greater than 2. Now, these thresholds are intentionally lower than standard population screening. So don't start screaming about how I've talked about the PSA, not worrying about those higher numbers. But this is reflecting the higher genetic risk in this group. Remember, genetically they were targeted. Okay. If PSA is elevated or imaging raises concerns, patients may be offered a prostate biopsy to determine whether clinically significant cancer is present. Remember, clinically significant cancer. That means we're talking Gleason score 7. And importantly, if cancer is found, treatment decisions are made collaboratively between the patient and their physician, ranging from active surveillance to definitive therapy. So what exactly is the PATROL study trying to prove? The primary endpoint is the positive predictive value of combining age-adjusted PSA thresholds and MRI findings for detecting clinically significant prostate cancer on biopsy. But the study goes even further. Exploratory goals include understanding tumor characteristics in genetically high-risk patients, tracking patient-reported outcomes over time, and collecting biospecimens to identify new emerging biomarkers. Participants may be followed for up to 10 years, especially if they choose active surveillance, with continued monitoring into long-term outcomes. The PATROL study represents a shift towards precision-based prostate cancer screening, where genetics, PSA trends, and imaging work together, not in isolation. As we move forward, studies like this may help redefine when to screen, how to screen, and most importantly, who needs to be screened. So, I'm Vic Senese, and this is UroNurse News. Sure to tune in for the next update. Coming this Saturday to UroPatient. This Saturday, we're diving into something many patients deal with, but few ever feel fully prepared for: intermittent catheterization. It's often explained quickly in the clinic, sometimes in a rushed and overly simplified way. But real life doesn't always match that brief instruction sheet. In this episode, I'm going to pull back the curtain on intermittent catheterization secrets, what your doctor didn't tell you. We'll talk about the practical details that make all the difference in day-to-day things like comfort strategies, timing routines, common mistakes patients quietly struggle with, and small adjustments that can dramatically improve confidence and outcomes. So if you ever felt unsure, frustrated, or like you were just trying to figure it out on your own, Tune in, because this is for you. Join us this Saturday for a straightforward, real-world guide that goes beyond the basics and goes deep dive into intermittent catheterization. So, for Uro patient, be sure to check that out tomorrow at 10:30 Saturday. There's the Saturday, uropatient.com. Now, tomorrow on UroNurse News, we take a deep dive into one of the most challenging and evolving areas of prostate cancer care, salvage prostatectomy after radiation failure. Yeah, we did a lot of prostate cancer this week. When prostate cancer comes back after radiation, treatment decisions get complicated fast. Surgery in a previously irradiated field is no simple redo. It's high stakes, technically demanding, and full of trade-offs between cancer control and quality of life. So I'm going to break down the recent narrative review covering who actually qualifies for salvage prostatectomy, what outcomes look like in the real world, and the biggest risk patients need to understand if they're going to try to go through this. So is salvage surgery still a curative option on the table after radiation therapy? Tune in tomorrow to see what the evidence says.
Thanks for watching UroNurse News. The expert's opinion in this communication are personal and not representative of any organization. They are for informational purposes only, not official guidance. Viewers are advised to use their judgment, seek additional advice, and take responsibility for any actions based on these opinions.